Okay. All right. Good evening, everyone, and welcome to Pacifica Institute. I hope you all had a nice chance to grab something to eat and mingle and get to know one another a little bit. And thank you for joining us tonight to discuss Ebola and what we need to know about it. Here at Pacifica Institute, we design projects covering social welfare, education, and poverty, alongside scholars, activists, politicians, and religious leaders in communities. Some of our projects and activities include humanitarian aid and emergency relief projects, lectures, panels, conferences, such as tonight, and social responsibility projects. Another activity we do is we host study abroad and interfaith dialogue trips to both Turkey and the Far East, to the Philippines, Vietnam, Cambodia, and Thailand. Thank you. And these trips are specifically geared to whatever group we take with us, whether it's professors and academics or religious interfaith leaders. We also have student trips that we're organizing for students in political science, journalism, and sociology and the humanities. So if anyone has any interest in that or would like more information, go ahead and come up and talk to me or Ilker, and we can provide you guys with more information about that. And tonight we have our special guests, Dr. Andrew Noymer and Dr. Michael J. Buchmeier, both with UCI, and they will share with us what we need to know about Ebola. Dr. Michael J. Buchmeier is professor of the Division of Infectious Diseases in the Department of Medicine, Department of Molecular Biology and Biochemistry, and the Center for Virus Research. Yes. Dr. Buchmeier has been the recipient of an American Heart Association Established Investigator Award, was elected a Fellow of the American Association for the Advancement of Science and a Fellow of the American Academy of Microbiology, and has been honored as a Burroughs Wellcome Professor in the Microbiological Sciences and an ASM Foundation Lecturer. He also serves as an editor of microbiology and molecular biology reviews and MBC Microbiology, and on the editorial boards of the Journal of Virology, PLOS Pathogens, and Viral Immunology. Dr. Andrew Noymer is Associate Professor of the Program in Public Health at UC Irvine, and he is a medical demographer and epidemiologist specializing in infectious disease mortality. Dr. Noymer's research mostly focuses on very long-run trends in infectious disease, from the disappearance of 14th century Black Death to the present. He has a PhD in sociology from UC Berkeley, an MSc in medical demography from the London School of Hygiene and Tropical Medicine, and an AB in biology from Harvard. So please welcome me in joining Dr. Buchmeier and Dr. Noymer. They'll each give a brief presentation followed by a question and answer period at the end. All right, thanks.
I guess that's my cue. Well, Ebola has been in the news. Anyone who hasn't heard about it probably has been asleep or traveling, hopefully not traveling in Africa. But what's the truth about Ebola? And I think what the message I want to leave you with today is that Ebola is an infectious disease, a very serious infectious disease, but there's nothing mystical about it. Ebola is an infection that with systematic approaches, with systematic study, we can develop drugs and vaccines that will combat the disease successfully. I think the other thing about it, and the message I think that was picked up so avidly by the press after we talked in October, is that Ebola is not a death sentence. Ebola is an infectious disease which can be treated effectively and can be cured. But what you have to do is you have to catch it early enough. We've had 10 cases in the United States so far. 2 people have died of the 10. The ones who survived were cases that were treated early. The 2 that died were people that were treated very late, too late for reversal of disease. And so this is the thing to remember, that you can in fact treat it. And I have no doubt that we'll be able to vaccinate to protect against it. That takes will. So what I want to talk about today is really the basics of Ebola. Looking at this virus, shape mine.
Have one, like,
Wired now. So everything I say is going to be recorded. All right, so this is the virus, Ebola virus. This picture actually was taken back in 1967 by a very good friend of mine, Frederick Murphy. Dr. Murphy at the time was working at the Center for Disease Control in Atlanta, and this is the first image that was ever taken of Ebola. We looked at it as virologists, and we said, what on earth is that? It doesn't look like a virus. This is in the area, in the time of, in science when we thought that viruses either were icosahedral, look like soccer balls, or that they were like bacteriophage with space modules, that had tails and had a head on the tail. And this was a totally new kind of virus, kind of a filamentous virus. This is the most recent summary that is up on the internet. And this should tell you something right away. This summary is October 29th. Before this, the summaries were posted weekly. This is the most recent one. So that's a tip-off right there that the authorities in public health feel that this epidemic is starting to wane. Now, that's important because in October we heard estimates from infectious disease experts that this epidemic was out of control, that it was going into a logarithmic phase and that it would expand exponentially until up to 1 million people died. And in fact, that's not happening. Why is it not happening? I think that's very important. Andrew is going to address that, not me. But why is that not happening? But if you look at it, this is the infection. So this is recent cases in red and all cases in each of these areas. And what characterizes this epidemic very differently from all the other Ebola epidemics is that it struck in the cities. So typically what happens in Ebola is that you have an epidemic in a small village, and it's contained within the small village. So if your village is 5 kilometers away from the next village, it's very easy to contain that epidemic. When you're in a city of 1 or 2 million people, like Freetown or like Conakry, Guinea, you have incredible crowding. You have incredible poverty in these cities, and there's no way that you can isolate people. Even so, family units who stuck together and who minimized exposure survived unaffected. So we know that even in those conditions, you can survive this infection. But there were a few cases exported to the United States, to New Jersey and to Texas, Dallas, Texas, and later a couple were transferred to Nebraska. Other countries, in Mali, in Senegal, and here in Spain, in Madrid. Patients were exported and hospitalized. There was a case in Hamburg, Germany as well. So this is the epicenter of this epidemic, and that's very different from the epicenter of previous epidemics in Zaire. So what is a filovirus? A filovirus is the family of viruses that Ebola belongs to. Is Ebola the only virus in the group? No. There's another virus called Marburg virus, which causes hemorrhagic fever, like Ebola does. But it's not as severe as Ebola. It doesn't quite have the number of weapons that Ebola has. There is also another virus which is called Reston virus. And this is a virus that probably comes out of Southeast Asia or perhaps the Philippines and is brought into first world countries in primates that are being used in research. And so it was first recognized in Reston, Virginia. And this is the virus at the hot zone, the book The Hot Zone is written about, where this infection started killing monkeys, brought into a U.S. Army facility in Reston, Virginia. And when this was worked up, they found this was Ebola virus. But it wasn't killing the laboratory people. It wasn't spreading to the laboratory people. It was only affecting the monkeys. So Ebola exists in human forms, forms that affect and kill humans, and in forms that affect primates but not human beings, and in Marburg virus. Marburg virus is a slightly different virus that was isolated from monkey kidneys that were shipped to Germany. back in the times when poliovirus vaccines were made in monkey kidneys. So looking at Ebola virus, there's a lot of mythology about Ebola. And I think you've probably heard over and over again that Ebola is not an airborne virus. Well, what does that mean? Ebola is not an airborne virus. It's not spread by airborne infection. Influenza is spread by airborne transmission. Ebola is not. Ebola is an infection that's spread by contact with body fluids or with objects contaminated with body fluids. And even that latter part is a little difficult to precisely identify because, we don't let somebody touch a door handle and then go back and test that door handle periodically. We would clean the door handle if we knew it was contaminated. So the risk here is contact with body fluids, and the body fluid has to touch either a mucous membrane, like the eye, it can be transmitted sexually, or it has to be ingested. So what we're talking about here is an infection that is ingested. It infects certainly the lungs and the upper respiratory tract, but it also infects the gastrointestinal tract, the liver, kidneys, major organs of the body. In those tissues, it affects mucosal surfaces, so the surfaces that line the blood vessels, the surfaces that line the eye, the mucous membranes. And the virus will grow on those tissues, and it grows very rapidly. In the body, the most critical cell in the early response is the mononuclear cell. It's the macrophage. It's the first line of defense that you have against infection. This is a non-specific. It's part of the so-called innate immune system, part of the natural immunity that you have against infection. This virus infects it and knocks it out. What other virus does that? Anyone know? Any of you students? HIV. HIV knocks out the antigen-presenting cell, the monocyte macrophage. It spreads then to lymph nodes, to blood, and then to multiple organs. So as you go through this sequence, you'll see different signs and symptoms exhibited. Virus has been spread by hospital-associated infections, nosocomial infections. These are infections that are spread within the environment of a hospital. We know that that can happen even in developed countries, where you have the spread of multi-drug resistant bacterial infections. In the case of Yambuku in 1967, the nosocomial infection was because of reuse of needles. In this hospital at the time, this was a hospital that was run in Yambuku, and it was run by nuns with the best of intentions. An individual came in who was sick, and the first thing that everyone was given as they came into the hospital was a shot of vitamins. And then they would take that needle and syringe and rinse it out, maybe rinse it out with alcohol, but not sterilize it, and then use it to inject vitamins into the next patient and the next patient until it was worn out. So you had the continuous reuse of syringes and needles, and because of that, you had an epidemic that resulted in about 80% mortality in hundreds, literally hundreds of people. In Kikwit, in Zaire, a surgical procedure was known to begin to start an epidemic. And finally, in Guinea, Sierra Leone, Dallas, and Madrid, we have no idea what the mechanism of infection was. We know in Dallas that when one individual was eventually hospitalized, the two nurses who took care of him were also ill. They survived, he didn't. Why did he not survive? He was hospitalized in a developed country. Because by the time he got to the hospital and was admitted, it was too late. Had he been admitted 3 days earlier when he first came in, we don't know what the outcome would have been. And that's why this timing is so important in this infection. Ebola virus has a range of incubations from 2 to 21 days. That's usually dose dependent. The amount of fluid that you are exposed to and the amount of virus in that fluid is what determines how long you will survive or how long you will go before you show symptoms. It's usually 6 to 12 days. You can have asymptomatic infections. People who are lucky and get a very low dose of virus may have an asymptomatic infection without symptoms. The diagnosis is done by laboratory techniques. The symptoms of Ebola. This is a wall in Freetown, in Sierra Leone, in Liberia, excuse me. And what this is basically is the way that you communicate the symptoms of Ebola to people who may be exposed. So it's a very traditional way of communicating. People who cough, who vomit, who perhaps have a headache, who diarrhea, muscle pains, etc. But it also introduces the next set of images about symptoms. The early symptoms are fever, malaise. What is malaise? Students? Come on, I'm a professor. I got to ask you questions. Malaise is a general feeling of illness. It's a general feeling of illness. It's how you feel when you're getting the flu, when you have a bad cold. That's malaise, except on Ebola, it's a very serious malaise. Fatigue and body aches. And these are typical symptoms early in a viral infection, not just Ebola infection. Yeah?
Is it okay to change this?
Sure.
Can we put inside of
Put this,
Yeah.
you can do that. Yeah.
Yeah.
I'm not sure it's any better there than it was here.
Okay.
Okay, this is good? All right. So if you look at the combination of these signs and symptoms in Ebola, it's very clear that the more of these you exhibit, the higher your risk of fatal infection. So the black line is fatality, the gray line is a non-fatal case. And what you're looking at is the number of people who exhibit dizziness, for example, in a fatal case versus a non-fatal case. The important thing here is not the individual lines, but the accumulation of these symptoms. So if you have fever, headache, weakness, dizziness, diarrhea, abdominal pain, sore throat, and vomiting, you're in big trouble. But if you have these things individually, you may not be. But fever and headache are common denominators in this infection. So high fever. You heard, I'm sure, on the news that when people came into the airports, they're screened for a fever over 103 degrees Fahrenheit. Excuse me, 103 degrees centigrade. Okay, and that was typical of the fever with Ebola. I'm sorry? Did I say for? I did so. Okay, there's a professor there. He's a professor of physics. I'm only a professor of medicine. All right. Anyway, so the fever is a common denominator with Ebola. Managing patients, and think about this. You're working at the equator. You're in equatorial Africa during the rainy season. And you have to dress up in a suit, which is waterproof. Several layers. You have on clothing underneath the clothing, and you have several layers of gloves on and several layers of sleeves. And you have 2 layers of mask and 2 layers of respirator to protect you from exposure. No skin can be left unprotected in this protocol. Each physician is responsible for 30 to 50 patients. The contact with patients was limited to 45 to 60 minutes, 2 to 3 times daily. And I don't mean with each patient, total. When you dress up in that suit, in these temperatures, you can only tolerate that suit for 45 to 60 minutes. And then you have to get out of the suit, cool down, rehydrate, before you can dress up again. So you get to do that 2 to 3 times a day. So you get to spend 1 to 2 minutes per patient. And this is one of the real handicaps of working under these conditions. Now, who does this? You've heard of Doctors Without Borders. These are volunteer physicians who are going over there and taking on the worst possible conditions on one of the worst diseases on earth. Why? Because you don't learn medicine by studying people that are well. You learn medicine by studying people that are sick. And if you have a gift that you can offer in a situation like this, it's of the highest, to me, is of the highest level of nobility that you can have. The course of infection. The onset of infection is with fever, malaise, and aches. And that begins anywhere from 0 to, well, it's probably 1 to 2 days. These get offset when they're changed from computer to computer. But it continues through the entire infection. I don't mean to say that this ends right here, but it begins here, and then followed by abdominal pain, and then followed by really what looks to be a recovery of the gastrointestinal systems, but what's really happening is your gastrointestinal tract is shutting down. First of all, there's no contents anymore. You haven't been eating. And secondly, you no longer have peristalsis active. And so you can't pass material through your digestive tract. Shock, and then finally gastrointestinal hemorrhaging and secondary infections will eventually kill the patient. So this is over a period of about 12 days in an active case. So patients die during this time frame. If you can stop the infection before it gets to this terminal stage, you have a good chance of saving the patient. And the way you do that is by treating, first of all, rehydrating, replacing electrolytes, and bringing that fever down and giving the patient a chance to recover. Experimental therapies, you've heard of a number of experimental therapies. ZMapp was developed in San Diego. ZMapp is a combination of antibodies that are grown in vitro. They're called monoclonal antibodies. They're single antibodies that are grown, and they're humanized. So you take an antibody made in a mouse and you convert it to a human format. And you deliver those antibodies, and hopefully those antibodies will neutralize or kill the virus. They don't always. But the real problem with ZMapp is that ZMapp is produced in tobacco leaves. And you can't produce enough ZMapp to treat more than just a few patients. So if you recall, when the first patients were treated with ZMapp, they said, well, we only have enough for 3 patients or 5 patients. And the reason is because they went into a partnership with a tobacco company who is promoting their technology. They're not using the best available technology, they're using their technology because they hold the patents on it. And so what you have is a technique that may be very useful, but it's limited in scope because you can't produce it. So what's happened since then is that those same antibodies are now being grown by Amgen up in Thousand Oaks, and they're being grown in huge fermenters, like you'd brew beer or wine. And you can make thousands of gallons of this stuff. And you can purify hundreds of milligrams of protein, and you can deliver antibody to a lot of patients. But you have to standardize that technology. You have to test the product and make sure it's working. So when you have an infection like Ebola, which cries for instant response, you can't respond instantly because you haven't tested all the technology you need to develop. So this is why it's so important to do the basic research on these diseases and then to be ready when the epidemic comes, rather than putting it off until the epidemic is here. You're trying to put the fire out when the house is already burning down instead of putting in sprinklers. All right, so ZMapp is one. This favipiravir is an RNA polymerase inhibitor. It inhibits the enzymes that's necessary for the virus to grow. It also works on influenza. So this is actually we call this repurposing a drug. It's a drug that's designed for one virus, and we say, well, it works on one virus, maybe it'll work on another virus. Sometimes they do, sometimes they don't. Viruses are not all identical. This one with the unpronounceable name is another antiviral drug, which acts in a variety of ways. This is another one, which is a so-called SI or interfering RNA, small interfering RNA. And then finally, this is another nucleotide compound that interferes with replication of the virus. None of these are perfect. They all work in vitro, and they all work in experimental animals. But do they work in the human? And do they work under the conditions that you're working with in Africa? It's one thing if you're doing an experimental study in an animal, and you have a set of monkeys that are waiting for you every day because they're right there in cages. And you infect them on day 1, and you can come back on day 2 or day 3 or day 4, and you can look at them, and you can measure how their disease is progressing. And you can give the drug at the optimal time. And you may be able to save those monkeys. That doesn't happen in real life. You're dealing with conditions that are very, very different in real life. So these experimental therapies have been approved to various degrees. And that's still a work in progress. There are also 2 vaccines that are being developed. One is sponsored by the NIH, that's this one right here, and the other is sponsored by the so-called New Link Genetics and the Canadian government. Both of them look promising. This is the one that was pulled off the market this week because it caused joint pain. Joint pain in itself is not a killer for a vaccine, but it does tell you that there's a potential problem. I've said this already, 10 cases of Ebola, All but 2 of those cases survived. So instead of the 50 to 60 to 70% mortality rate that you see in Africa, you're seeing 20% mortality rate. So that's a huge difference, just a huge difference right away. And it tells you that when a patient can be evacuated early in the disease, you can save them. If you wait too long, you won't be able to save them. So this is what the outbreak looks like as of October. The countries of Liberia, Sierra Leone, Guinea are the most heavily affected. The epidemic started, by the way, in Guinea, up in this area in Guinea. But it spread quickly to Sierra Leone and Liberia, where the crowding and the poverty is much greater than it is in Guinea, and spread like wildfire in these areas. These H's are hospitals here, here. There's another hospital up here, Bouquet, that I've been to, and down in Sierra Leone. But these hospitals are not what you think of as hospitals. These hospitals are more like what we would think of as clinics. They're not highly developed hospitals. They're not set up to take care of large numbers of patients in an emergency situation. They're there really to deliver babies, to do appendectomies, to do this sort of thing. They're not set up as an emergency isolation hospital. The other problem that becomes very difficult when you have 7,000 to 10,000 people die is disposing of bodies. And here you have the workers who are disposing of bodies from probably this neighborhood in Freetown. And you can see that, first of all, these people are in anguish. They've just lost a relative, but they're also frightened. And people who come in dressed a bit like space aliens, you know, maybe even adding more fear to this situation. And in fact, one of these groups who was responsible for monitoring a town in Guinea was murdered, because the local people felt that maybe these people are introducing the Ebola to the community, not preventing it. You know, there's a lot of kind of traditional medicine mysticism that goes along with something like this. So disposal of these contaminated bodies is a huge problem. And that's, I'm sorry?
How are they disposed of?
Well, they're disposed of by sanitizing, by wrapping in plastic, and then burying. They're not burned. I'm not sure quite why they're not burned unless there's a cultural prohibition. Yeah. You should know, ladies in the audience, you should know that these diseases typically affect women much more than men. Why is that? Is it because women are more susceptible? No. It's because women are in the line of fire. In these communities, particularly in the traditional rural communities, the women are responsible for nursing the sick, for managing the household, and for preparing the dead for burial and burying them. And so they're exposed. And with many of these diseases, women are much more at risk than men. Just a couple of more pictures here, preparing a coffin, spraying the inside of the coffin with disinfectant. Here, another individual being evacuated, probably not dead in that case. And here, some of the civil unrest that has happened because of this. You can imagine the rioting, the civil disorder that can happen when this happens. And in fact, it doesn't just happen in a third world country like this. It happens directed against, for example, here the Liberian soccer team, who was not even in the country during the epidemic. But their host countries that were hosting matches would not let them play against the team. They wouldn't let them in the locker rooms. They wouldn't let them eat, you know, in public restaurants because of the fear that they were carrying Ebola. So this is the kind of irrationality that can spread like wildfire. And finally, in our own country, this is protesting in front of the White House. So the irrationality doesn't just exist in Africa. I'm just going to cover one more element of this, and then I'm going to turn it over to Andrew. This is a virus that grows to very, very high levels. You get an idea here in a couple of infected cells. These filaments, these fibers, are Ebola viruses ready to be released from the cell. So it grows to enormous quantities. Here the virus is being released from the cell, extruded out into the medium, and you see these long filamentous bodies. These have a membrane on them, these do not. So these are fibers here that will be pushed out through the membrane, and as they go out through the membrane, you may see right here that they're picking up the membrane from the cell. typical of RNA viruses. The pathogenesis of this virus, in other words, the way the virus causes infectious disease, is by disarming the innate immune response of the host. And it does this in a way that does not allow the innate immune response to communicate with the antibody and T cell response to produce a viable immune response to the virus. And so what happens is you knock the virus down, you knock the immune system down, and you conquer it. That's a very typical story with many infectious diseases. What happens with Ebola that's very interesting, Ebola produces two glycoproteins, one that exists on the surface of the virus and is the receptor binding component of the virus, the one that picks out the right target cell and initiates infection. But the second is a soluble glycoprotein that's shed in enormous quantities and seems to bind to TLR4, which is a response receptor on the phagocytic cell, in this case the dendritic cell, which is the first responder in the immune system. And when it does that, what it does is it causes that cell to release a number of soluble factors which act at a distance on blood cells and on endothelial cells and on macrophages and on B and T cells and hepatocytes and renal cells and causes all of these cells to malfunction. And so the virus really poisons the system by causing that release. And that's really the essence of the pathogenesis of a virus like Ebola, that it gets in and totally disrupts the immune system and causes the immune system to fail to respond properly. Now, if you have an antibody already from vaccination, you could block that. You can block this event, you can block and remove that soluble glycoprotein from the system. And when you do that, that's the expectation that you have with the vaccination. So you can respond. So I'm going to jump ahead and just say that Ebola is not only lethal for humans, but Ebola is lethal for all primates. And in the case of the lowland gorilla, the population of lowland gorillas in West Africa has been virtually destroyed by Ebola. And this is happening away from humans, it's happening in the wild, and it's happening largely because of the curiosity of these great apes. Because if a great ape finds a dead animal, if it's a silverback like this, he probably has a troop of a number of other gorillas, and they will stop and they will investigate it, and they'll handle it, and they'll turn it over, and they'll do all of the things that a human does to be exposed to this virus. And then they die. So I'm going to leave it at that and turn it over to Andrew. Oh, I'm sorry. Yes, get this. Wait for the microphone.
Oh, sorry.
Thank you.
You put my phone on the desktop. Is it okay to put the mic? You can put it wherever you want.
Yeah, there you go. Yeah, hit Control L. Control L.
So you want to put it inside the...
You put it wherever you want.
Thank you.
Thank you. Great. Can everyone hear me? Thanks, Mike. So Mike did a great job going over most of the aspects of transmission. I'll talk about some of the societal aspects of it and of the epidemiology and the impact, and I think there'll be time for Q&A from both of us at the end. I'm going to say also a little bit more about the disease ecology and emergence, which Mike touched on at the end of his talk. Obviously, we saw this a few moments ago. Just to give you a sense of just how small viruses are, this basically looks like a piece of spaghetti. And if it were actually a piece of spaghetti in scale, then a human hair would be the size of the trunk of a redwood tree. Okay, so that's just how small we're talking about. It's not just microscopic; it's submicroscopic. These are electron micrographs. So the smallest droplet of water is like a swimming pool or an Olympic-sized swimming pool to a virus. So they can be spread easily. Mike's already gone over the symptoms. So what sparked this epidemic, this outbreak of Ebola, the 2014 outbreak, or any of the previous ones? How does it get into humans? Ebola seems to only infect mammals. As Mike says, it infects not just humans, it infects gorillas. It's an episodic zoonosis. And I'll say what that means in a second, but let me just say the wild animal reservoir is not known definitively. Fruit bats are sort of the leading suspect, but we don't know exactly what animal brought this outbreak to humans. When I say it's an episodic zoonosis, so a zoonosis is an infection that comes to humans from the animal kingdom. And that is a major motif in all infections. I mean, if you go back long enough, almost all infections come from animals. So measles is related to canine distemper, and influenza virus comes from birds. In fact, the reason we have so many different strains of flu is because we're always getting new strains from birds. And so for an infection to be zoonotic is not unusual. In fact, it's the norm. But unlike measles, which probably came into humans when we domesticated wild dogs, an episodic zoonosis is one that comes and goes between the animal kingdom and the human kingdom. So we've had outbreaks since 1976 of Ebola, and then they burn out, and then we get it again. So it hasn't become endemic to humans.
Why do they burn out?
Well, I mean, as Mike touched on briefly in his part, the outbreaks have typically occurred in rural areas, and it's been, so a village in, far separated from other urban centers, and so it just hasn't spread from there to through communication networks to larger cities. And West Africa is a lot more densely populated than Zaire and Central Africa, where the outbreaks have occurred before. And I think partly also there's been a little bit of luck involved. And partly also, remember in 1976, to get anywhere in rural Africa took a lot longer than it does today. This is a fruit bat. They can be quite large. And this is, they're nocturnal in their activity. So during the day, they do what this guy's doing, which is hang upside down from a tree and rest, okay? So these among other wild animals are hunted for protein in Africa. And hunted animal protein for human consumption is known as bushmeat. And the estimates are in Central Africa that are about 1 billion kilograms of bushmeat is consumed annually. So this is not like a ritual thing or something unusual that humans are consuming wild animals in Africa. This is the everyday life in rural Central Africa. Is that one of the ways you put food on the table for your family is that you hunt wild animal protein. Okay, so there's nothing sort of strange about this at all. I mean, this, people are consuming wild animal protein in Central Africa every year. And so you don't get Ebola from eating cooked food, but someone killed and butchered an animal, and the fluids of the blood of the animal can get into humans through a small nick in the finger, and then you have a case right there. And the first case was about a year ago in a 2-year-old in rural Guinea, and then with gradual spread to the capital of Guinea, Conakry, and then to neighboring Liberia and Sierra Leone. One early case in a traditional healer in Sierra Leone led to 14 genetically linked cases in women who attended her funeral. So, and here is a map of the probable spread of the first cases which emerged in Guinea from this rural area eventually to the capital, Conakry, in Guinea. And here is a map similar to the one that Mike showed of the dynamics of the current outbreak. These are the cumulative incidences. So here we have Guinea, a former French colony, and then and here we have Liberia, which is a country that was colonized by freed American slaves. And in the middle of the two, we have Sierra Leone, a former British colony. And the capital cities are Conakry, Freetown, and Monrovia. Monrovia named after James Monroe by the American slaves who colonized this country. So the darker shading indicates more incidents. And so Guinea has been largely spared, and in fact in the north, there have been some districts in Guinea which have not seen any cases, but in Sierra Leone and Liberia have been really hard hit. And in fact, Sierra Leone is, it's really becoming sort of the center of the outbreak, and it shares a land border only with two countries that also have the Ebola outbreak. So it's really sort of at the center of things. And these borders are these are colonial borders. So in rural areas, people cross them. The language groups and so on, don't respect the 19th century colonial boundaries. People trade with other people in other countries. And so the borders are sort of porous, and that's why we've seen all three of these countries have outbreaks. The countries that have been affected are the three that we've talked about: Guinea, Sierra Leone, and Liberia. There were 18 cases in Nigeria, but contact tracing from the polio eradication effort, which is ongoing, helped stop the spread in Nigeria. There was also a little bit of luck in Nigeria, because when the patient who came to Nigeria arrived, the hospitals were closed because of a strike. The public hospitals were closed, so he went to a private clinic. And the private clinic was much better equipped to deal with his symptoms and to contain the illness than, I don't know how many people here, I have, but I don't know how many other people here have been to a public hospital in sub-Saharan Africa, but believe me, it's a chaotic place and bears no resemblance to your Kaiser or Hoag hospital here in Irvine. So it was just a little bit of luck that the hospitals were on strike when he arrived, and he went to a private clinic instead. In Senegal, there were cases. I highlight Mali here because Mali shares a border with Guinea, but the cases in Mali were also contained. So unlike the early days of the epidemic, where for 3 months it was rumbling along in Guinea and nobody really knew anything, and the WHO wasn't paying enough attention, we're really on top of the situation now, and everyone was worried about Mali, but it's under control now. Here we have, there were cases in USA and Spain, as Mike mentioned, and the two means that there have been 10 cases in the US, but 2 of them were acquired in the US. The other 8 were people who were evacuated by air ambulance to the US from West Africa. And there was 1 case of transmission in Spain. So these 3 cases are the only cases of Ebola that have ever occurred, as far as we know, outside the African continent. And when we were, Mike and I were doing some Ebola events in October, everyone was really, really panicky about, Ebola is going to sweep through the United States. And I really just want to emphasize that there have only ever been 3 cases of Ebola that have occurred from transmission outside the African continent. And all 3 of them were nosocomially acquired, not community acquired. So you can't ride the bus and get Ebola. You have to be a nurse caring for someone who's sick with Ebola. Another thing I'd like to mention is that as far as we know from all the genetic work that's been done, and there has been quite a bit of it done, this was based on a single introduction. So in other words, there was some single animal, perhaps a bat, that introduced the virus to humans, and then from there, it's all been human-to-human transmission. We don't have multiple sources for the outbreak. This is the most recent. This is the most recent situation from the CDC, from the most recent issue of the Morbidity and Mortality Weekly Report, and we see that again that Sierra Leone and Liberia seem to be the current centers of transmission. Things are cooling off a little bit in Guinea. Here is the cumulative incidence in the current outbreak. So Guinea, in the early days of the epidemic, was the highest, but since then has really grown a lot slower. And Liberia and Sierra Leone, which are also more populous, have taken over as the worst centers. And everyone was talking about Liberia for a long time, and it was throughout the fall sort of had more cumulative cases than Sierra Leone. But in the last week or so, people have really started to worry more about Sierra Leone, because as you can sort of see, it's sort of slowing down in Liberia and just seems to be going up in Sierra Leone. This is another depiction of similar data. In the interest of time, I'm going to just skip over this. Mike touched on basically a lot of this. Let me a lot of the points in this slide. Let me just reiterate the two last points. The first is that transmission of Ebola occurs only from symptomatic people. So if someone is sick with Ebola, there's this incubation period that Mike talked about. That's when the virus is replicating in the person, but the person has no symptoms or maybe just a malaise. That person cannot transmit Ebola. Only when the vomiting and the high fever begins can that person transmit Ebola. We used to call it Ebola hemorrhagic fever, but frank bleeding is not common in all cases, so we just tend to call it Ebola virus disease nowadays. But only those people who are symptomatic can transmit. And the viremia is pretty intense. There are 10 to the 8th viral particles per milliliter of blood at the peak of the epidemic, at the peak of the infection in a person. And here's just an infographic from the CDC saying some of the things we talked about. Ebola only spreads when people are sick. The likely host is bats. So Columbia Broadcasting asked me in an interview if I would fly on a plane, where someone had Ebola, had flown on a plane, because there was an instance where some of the Dallas nurses, had gotten on a flight. And the answer is I would get on a plane. If they weren't showing any symptoms, I would get on a plane where they had been flying. Because if they're not sick, there's nothing that they can do to contaminate the seat that I'm going to be sitting in. I would gladly. And this is a really important point. Here's another infographic. It's not airborne. You can't get it through food. You can't get it through water. The Ebola virus is not a very environmentally robust virus. It just doesn't do very well outside the host. Unlike, say, norovirus, which is responsible for the cruise ship outbreaks of gastroenteritis, which does survive for long periods on doorknobs and railings and so on. So Mike talked about there's no vaccine yet. People are working on it, and the personal protective equipment, the PPE. Is so important because so many cases have been among healthcare workers. And that's just, I think the protocols have been pretty well worked out at this point. Here's a picture of safe safe burial. Mike touched upon this. Cremation is not considered culturally appropriate in these countries in West Africa, which is why it's not being done. Cremation would, in the textbook sense, be the first choice for disposal of bodies. But here's just a guide on hospital infection control for viral hemorrhagic fevers. So the interruption of the transmission is basically what the WHO and the UN and Médecins Sans Frontières, MSF, Doctors Without Borders, is working on now. It centers around meticulous infection control in healthcare settings through use of barrier precautions, gown, glove, eye, and mask protection. Respiratory isolation in the strictest sense is not necessary. So doctors are often wearing like an NP95 respirator, which is just a basic mask that you could get at Home Depot if you're doing some fine sanding and you don't want to inhale all the dust. One of those masks is considered a respirator in the technical sense, but it doesn't need to be sort of an astronaut spacesuit style respiratory isolation that you may have seen in some Hollywood depictions of the epidemics. And this last one, condoms. So one interesting thing is that the Ebola virus seems to persist in seminal fluid of men who have survived an infection and who have no detectable Ebola virus in their blood. And so safe sex is definitely going to have to be something that is practiced in these countries. It's not clear if it's a minority of male survivors or not, but there do seem to be some isolation of viable virus from seminal fluid, even after someone has survived an outbreak and has no detectable Ebola virus in the bloodstream, which is it's a little strange. But that's going to be something as they do the mop-up operations. I hope they'll be providing lots and lots of condoms. Here is an Ebola treatment center set up by MSF. As Mike said, these are not what you would think of as a Western-style hospital. Even in the best of times, the healthcare in sub-Saharan Africa is not like a Western-style hospital, and it's certainly not during this crisis. People always ask, can you get a vaccine yet? Or is there a cure? I think vaccines are obviously how we combat major viral diseases. Everyone here has probably had their measles shot, I hope. If you're below a certain age, you've had your chickenpox vaccination. If you're above a certain age, you had to get chickenpox, like some of us did. Vaccines are so crucially important. But we need to strengthen health systems in sub-Saharan Africa because the next outbreak could be, Marburg. And there's a good chance that the eventual Ebola vaccine won't also protect against Marburg. Or the next outbreak could be a virus unknown to science as of this date. And, so vaccines are great, but we also need to strengthen health systems in sub-Saharan Africa. That's so important.
Basically, those establishments over there are not good enough to interrupt the spread.
Well, no. These are temporary hospitals. I mean, they are doing the MSF has been doing such a heroic job, and the fact that Guinea cases are down, and I'll say a little bit more about the scale of the epidemic on a later slide. But the international community is getting things under control. It will probably be another 12 months before we can say West Africa is Ebola free, which means that it will be a 24-month outbreak in total, which is, by far longer than any previous outbreak of this disease. But but they are being effective in the sense that we're getting the upper hand on Ebola. But trust me, the typical public hospital in sub-Saharan Africa is nothing like the equivalent in Western Europe or North America. So to date, there have been almost 20,000 confirmed cases of Ebola in these 3 countries. Again, that's more than all the previous outbreaks of Ebola combined since its discovery in 1976. And about 12,000 of these have been lab confirmed. And there have been almost 7,000 confirmed deaths. So that's a tragedy, clearly. But there's just something that I think needs to be said more often. Is the 3 affected countries have about 20 million population. And in a normal year, they have about 215,000 deaths from all causes. Okay, so I mean, people die. 215,000 a year in a normal year from the things that we die from, like heart disease, from things that we don't die from, like malaria, and in developing countries, there's a scandalously high death rate from road traffic accidents. So, I mean, the Sierra Leone, Guinea, and Liberia have not become some giant ghost town because everyone's died. There have been 7,000 deaths, and there are 215,000 deaths in a normal year. I saw something in one of the media reports that the cemetery in Freetown had no more room. Well, I mean, that may or may not be true, but if it is the case, it's not because of the Ebola epidemic. It's because they didn't plan the cemetery very well, because there are 215,000 deaths a year in these countries, and there have only been 7,000 Ebola deaths. So these countries have not become a giant ghost town, and life goes on. And there's been, of course, an increasing number of people who, through asymptomatic infections and through surviving symptomatic infections, who in fact are immune. And some of the workers in these clinics are survivors who have natural antibody protection. Here's a slide about the USA. I mean, the American hospitals are now really up to speed on personal protective equipment and the procedures for its donning and doffing. Doffing is very important. Doffing is probably where more infections occur than donning. All the UC medical centers have been designated as Ebola ready. So the UCI Medical Center in Orange and all the other UC medical centers are designated Ebola ready, and there are other hospitals in California that share that designation. And there are some national level centers like Nebraska, Billings, Montana, the NIH Clinical Center in Bethesda, and the Emory Hospital in Atlanta, which are national level hemorrhagic fever treatment centers. Mike already talked about the 21-day maximum incubation period. Returning healthcare workers do not need to be quarantined. They need to self-monitor, but they do not need to be held against their will in a quarantine. They should be, we should be building a monument to these people, not locking them up in a quarantine. The real danger is in Africa, not of imported cases in America. The situation is being tackled. I'm confident that in approximately a year we'll have no more cases, but we're not certainly out of the woods yet. I mean, we're not talking, it's not going to be February or March. It's going to be more like a year from now, okay? The early model estimates, which were the CDC produced, which were on the order of 1 million cases by mid-January, were alarmist in the sense that I think they were, even the CDC knew that probably wasn't going to come to pass. But the worst doom and gloom situations have indeed not come to pass, and that's a good thing. And it has been incredibly disruptive to the society in these 3 countries, and I keep hearing, concerns by the World Food Program of the United Nations and other bodies about food because it's going to be a 24-month affair. So we're talking at least 2 harvests. And it's not, as I said, it's not the numbers dead because those are relatively small, but just the social disruption that has occurred in these 3 countries. And feeding everyone is going to be a concern. I do believe there will not be a famine in these 3 countries because people are on top of the situation, and the World Food Program of the FAO is going to, step in if needed. But it's something that, an epidemic of this magnitude is more than just the actual medical dimension. It's also the human dimension. Those are all. Just one last slide. This has been making the rounds on social media. So people have been worried about Africa, and people have been canceling trips, safari trips to South Africa and Kenya and so on. So here's these 3 countries. That's where there's Ebola. And then everywhere else there's no Ebola. Okay? So that's worth keeping in mind as well. The African continent is very, very poorly understood in the United States often. So there's some information up on this website at the UC Irvine, and I think Mike and I can now take your questions.